So I am just covering those parts which have not been discussed in the hemodynamic monitoring. Cardiac output monitoring, should we use cardiac output monitoring? This paper is not new, it's published around 9 years back, but it still holds true that they do not recommend routine measurement of cardiac output for patients with shock responding to initial therapy. Look at the statement, they are saying those patients of the shock who are responding to initial therapy, but in those patients they recommend measurement of cardiac output and stroke volume to evaluate the response of fluid or inotrope in patients that are not responding to initial therapy. So if my patient is responding to my initial fluid resuscitation, I don't need any cardiac output monitoring, but is not, then probably yes. So these are the situation. Look at here. With the fluid correlation with the fluid volume expansion, there is a correlation between pulse pressure and cardiac index, but there is no correlation between pulse pressure and cardiac index and the fluid resuscitation in patients where norepinephrine is already started. Why this is happening? As we have talked about the arterial tone, vascular tone, because of the noradrenaline, that tone has changed. That is why there is no linear relationship between volume expansion and the changes in the cardiac output or stroke volume. That has to be kept in mind here. So in those patients, we probably need the advanced cardiac output monitoring. And as you can see in these patients also, there are in heart rate does not change, does not detect the fluid response. Classically we say if a patient is having hypovolemia, we give fluid, heart rate will settle down. But in a patient, certain patients, in a septic patients, many times this change of heart rate is not accompanied with the fluid resuscitation. They continue to be tachycardic. So there is no reliable thing in those patients how to assess the volume responsiveness. So many times we require a cardiac output measurement. These are the conditions. Patient, only the most severe patients who require it, patients under vasopressor with cardiac impairment, where we are indices, we want to have another indices like tissue oxygenation, SCVO2, lactate, PCO2 gap, etc. Be aware of the inherent limitation of the cardiac output measurements. The true value, they are higher than the last significant changes. So true value, sometimes there could be error in the measurement. So value may change and we can have a wrong interpretation. So trust value if they are at the higher than the last significant change, least significant change. Do not use cardiac output monitoring in the patient where it is contraindicated, like in patients of the severe arteriopathy. If the peripheral vascular disease is there, then radial artery may not be a very correct thing, and all the parameters like PICO, whatever we are using, flow track we are using through the radial artery, that vascular tone is changing, so they may not be correct. And do not use over optimistic algorithms. Be clever, use your clinical sense as well. So there is a change in the paradigm in the cardiac output. Earlier we used to have more invasive thing, pulmonary artery catheter was there. Now the era has moved to minimally invasive in the form of pulse pressure analysis, Doppler in the form of echocardiography, then bioimpedance or bioreactance, and applied Fick principle. I'll just touch upon few things about these. So invasive, why we require modification of pulmonary artery catheter? And what are the modifications? So mainly four techniques are there, principles: pulse contour analysis and transpulmonary thermodilution is there. It could be calibrated, non-calibrated, echocardiography or esophageal Doppler, partial carbon dioxide rebreathing with application of the Fick principle, and electrical bioimpedance or bioreactance. So I'll just touch upon, I'll discuss about little bit about the thermodilution. What is the advantages of pulmonary artery catheter? It is giving a continuous cardiac output monitoring, provision of important hemodynamic parameters as PSC is there, indicated in situation where less invasive techniques are contraindicated or fail to provide accurate cardiac output values. What are the disadvantages? It is invasive, costly, and complication associated with pulmonary artery catheter. So coming to minimally invasive cardiac output, as we have already discussed these things, arterial waveform analysis, basic principle is stroke volume can be continuously estimated by analyzing the arterial pressure waveform obtained from the arterial line. This is the first principle. Second is arterial pressure waveform are affected by the interaction between stroke volume and the individual vascular compliance, as we discussed about the arterial tone, and aortic impedance and peripheral arterial resistance. So three things are there: vascular compliance, aortic impedance and peripheral arterial resistance. All three along with the stroke volume will define your blood pressure. Prerequisite: optimal and stable arterial waveform signal without any damping. If damping is there, signals are not true, whole reading will go haywire, the cardiac output reading. So advantages: almost continuous data of cardiac output, stroke volume and stroke volume variation, provide information of preload. Disadvantage: minimally invasive, may not be true, may not be very good, like accurate. Optimal arterial pulse, the signals are there if there is a arrhythmia, damping, and you are using IABP, and of course if you are using the ECMO, again the readings may go haywire. Anything which is changing the vascular tone. Uncalibrated devices are flow track or Vigilio. As you know all, the main points are, main parameters are pulse contour, cardiac output, arterial blood pressure, heart rate, stroke volume variation, pulse pressure variation, systemic vascular resistance, and index of the left ventricular contractility. These are the parameters. Why I am just touching these? Because they may be asked in the exam. Calibrated devices are LIDCO, PICO Plus, and this EV1000. How they work? I just touch upon the LIDCO. In LIDCO, lithium chloride injection is being given, is 0.002 millimole per liter solution is injected in the central vein in a peripheral administration. As you can see here, in the central vein it is being administered, and we measure the changes in the radial artery. So arterial plasma concentration is measured by withdrawing blood across the lithium selective electrode at 4 ml per minute. Cardiac output is calculated from the lithium dose under the area under the primary concentration time curve before recirculation. Coming to what is transpulmonary thermodilution. So two type of thermodilution you know. One is done by the pulmonary artery catheter and another is transpulmonary. As the name is, pulmonary artery catheter thermodilation is being done through the line, central line, and we are measuring at the pulmonary artery. So we are just measuring the changes which has happened in the right heart. Whereas transpulmonary thermodilution, as the name suggests, as you can see here, the cold saline is injected in the central line, and we are measuring here in the femoral vessel. So the changes are traversing through the right heart, pulmonary vasculature, left heart, and then they are. So we are looking at all three conditions: right heart, pulmonary vasculature, and left heart. That is the difference between the thermodilution by pulmonary artery and transpulmonary thermodilution, as you can see here. This is the transpulmonary thermodilution by PICO or volume view, where we are injecting in the central line and measuring in the arterial. Whereas in the PA, we are injecting somewhere here and measuring somewhere here. These are the graphic presentation. What we are measuring after central line injection, the cold bolus sequentially passes through the various intrathoracic compartments. They are important to remember. Right atrium, as we know, whatever is being injected into the central line, it will go ultimately to the right atrium, to the right ventricle, to whole of the lungs. So right heart, lungs, and the left heart. And then we measure the changes by the sensor at the tip of the arterial catheter. Coming to the intrathoracic compartment, what could be the compartment? One is the right side of the heart, the lung, and the left side of heart. Any doubt? So in lung there are two compartments: the pulmonary blood volume and extravascular lung water. Pulmonary blood volume is the volume which is there in the capillaries, right? And the extravascular lung water is which is seeping out, leaking out from the pulmonary capillaries. So this is the total mixing chamber. This whole, if I combine, is called as a pulmonary thermal volume, because as you can understand, in the thoracic area, this all is the thermal volume. Why it is largest mixing chamber? Because RA, RV, they are, although same blood is traversing from here to here, the amount is same, but this is the largest chamber because it is having so many capillaries. So blood has to traverse to so many capillaries. So it's the largest chamber, area wise, not volume wise. These are the different parameters which we can measure through transpulmonary thermodilution, like cardiac output, global end diastolic volume, intrathoracic blood volume, extravascular lung water, pulmonary vascular permeability index, cardiac function index, and global ejection fraction. So this is how cardiac output is calculated, by analyzing the thermodilution curve by using modified Stewart-Hamilton algorithm. It has got two components. So one is the mean transit time. Mean transit time is the moment you are injecting. Here we are injecting and up to where we are sensing it. So the mean time required for indicator to reach the detection point. In thermodilution it is the cold saline, whereas in the LIDCO it is the lithium. So that is why I have written here the indicator. This is the downslope time. It is the exponential downslope time of the thermodilution curve. So it is the decay or downslope when it is mixing into the different blood and decaying it. So just what are these? Intrathoracic thermal volume and pulmonary thoracic thermal volume. So intrathoracic thermal volume is the everything, whatever it is, and the pulmonary thermal volume is pulmonary blood volume plus extravascular lung water, because this blood which is traversing from RV to the lungs, some amount is being leaked here. It could be less than 10%, it could be more than 10%, but it is leaking here. That's why this we have to calculate. The intrathoracic thermal volume is the mean slope into cardiac output. The pulmonary thermal volume is the downslope into cardiac output. That's how all the calculations are based. As you can see, what is the global end diastolic volume? In pulmonary artery catheter, we can take out the individual chamber because we are talking about the right and left separately, and we are measuring only the right chamber. So whatever measurement we are doing is based on the output of the right chamber, not the left. We take it as a cardiac output, but certainly it is not a complete cardiac output. It is the output of right ventricle, what we are measuring with the pulmonary artery. Here we are measuring combination of both the ventricles. So that is why it is called as a global end diastolic volume. Global end diastolic volume is if in the intrathoracic thermal volume we remove this pulmonary thermal volume. So what is left? The blood which is at the end of the diastole, which is left in the ventricles or atria. So that becomes the global end diastolic volume. Intrathoracic blood volume is global end diastolic volume plus pulmonary blood volume. So here everything is there in the intrathoracic blood volume except the extravascular lung water. Extravascular lung water is what? Intrathoracic thermal volume, which is having everything minus intrathoracic blood volume. Just remember, this some fluid has been exudated out to the lungs in the form of extravascular lung water. So that extravascular blood, the volume which is going out from the plasma is also having some thermal capacity. That's why this difference is there. So extravascular lung water is difference between intrathoracic thermal volume minus intrathoracic blood volume. Pulmonary vascular permeability index is extravascular lung water divided by the pulmonary blood volume. So it is helpful in differentiating two types of the edema, whether the edema, lung edema is hydrostatic, as we see in the form of, where we see the hydrostatic, cardiogenic pulmonary edema is a hydrostatic. In a sepsis we see a permeability because of the impaired permeability. So this index can differentiate between two. In a hydrostatic pulmonary edema, you will find that there is an increase in the pulmonary blood volume, that is sure, because some fluid is leaking out, so pulmonary blood volume will increase. But extravascular volume is also increased because that is also leaking out from the capillaries. Whereas in the permeability based, the pulmonary blood volume will remain static, only the extravascular lung volume will increase. So if this pulmonary vascular permeability index is normal between 1 and 3 and we find there is a lung edema, it is because of the hydrostatic changes, cardiogenic shock, cardiogenic pulmonary edema. If this pulmonary vascular permeability index is raised more than 3, then we are sure that it is because of the leaky capillary, it is because of the sepsis probably. Global end diastolic Fraction, global ejection fraction, as we can see, the right heart, this is the right ventricle, right atria end diastolic volume, right ventricular end diastolic volume, then the stroke volume is traversing through the lungs, left atria end diastolic volume and left ventricle end diastolic volume. So if we combine these chambers, it becomes the global end diastolic global ejection fraction. This is the ejection fraction of 4 chambers. So they have multiplied it by 4 with the this stroke volume and divided by the global and diastolic volume. So that gives the global ejection fraction. So in a patient who is having circulatory shock, we put a line, C line, or we start echocardiography. These 3 things are in the basic hemodynamic monitoring. If my patient is having a ARDS, then severe right heart failure, severe pulmonary hypertension is there, then one can go for a PA catheter. If there is no right heart failure or pulmonary hypertension is not there severe, one can go for transpulmonary thermodilution. If the patient is not having ARDS, initial treatment, improvement. If no improvement, then you can go to the other same algorithm again. So limitation of transpulmonary thermodilution cannot be used with an intra-aortic balloon pump or cannot be used with the ECMO, because in the ECMO also the dynamics will change. Should be recalibrated with changes in the position, therapy or condition to account for the compliance of the vascular bed. So what is happening? Your patient is maintained, suddenly patient has hypotension, you are increasing the dose of NORAD. At that point of time, the vascular tone will also change. So we should recalibrate, or we should redo the thermodilution at that point of time, because dynamics has changed. In obese patient, extravascular lung water underestimate as related to the weight of the patient. So one should use the ideal body weight when we are feeding in the machine. Extravascular lung water only measured in the parts of the lung that are perfused. So it underestimates in those patients who are post-pneumonectomy, having pulmonary embolism, etc. Abdominal aortic aneurysm raises the global end diastolic volume and intrathoracic blood volume. Severe aortic regurgitation may result in the inaccurate thermodilution washout curve. So reading may be inaccurate. Few slides about 1 or 2 things which can be asked in the exam is the bioimpedance or bioreactance. Now many centers are using the new monitor, this bioreactance based on the bioreactance. What is happening? We place these type of electrodes. 4 electrodes are placed at the given location. An electric current of known frequencies applied across the thorax between outer pair of the sensor. So that's how we apply this. And the signal is recorded between the inner pair of the sensor. So electrical current is being passed here and we measure the electrical signal from here. At the heart, as the heart expands and contracts, a time delay or phase shift is created in the current by blood flow. This phase shift is measured, and by this calculation of this phase shift, these monitors give the cardiac output. These are the different parameters: cardiac index, cardiac output, heart rate, stroke volume index. Stroke volume can be calculated by this machine. Volume clamp method, this is also coming up by a few companies. In this, there is a cuff which is applied over a finger. Photoplethysmography measures the diameter of the finger arteries. This cuff is little bit deflated and relaxes to keep the diameter constant. What is happening? During the pulse, when the cardiac output is being there and pulse is there, these arteries, small vessels, they extend and collapse many times. Like, not collapse is the wrong word, but they expand and come to normal expand. That is how we feel the pulse in the hand. So same way. So this cuff inflates and relaxes to keep the diameter constant. With this diameter constant, they measure the plethysmography, pulse contour analysis estimates the cardiac output. But again, whether these devices accurately estimate arterial pressure or not is to be discussed. This device has come up in the India. I am not sure whether anybody is having this device. Edwards has come up this type of device in India. So to conclude, hemodynamic monitoring enables early detection of change in the patient's condition. New technologies provide reasonably good result with less invasiveness. Always correlate the reading finding with the clinical picture in order to provide the best treatment option. No monitoring device will improve outcome unless coupled to a treatment which improves outcome. Thank you very much.